Hello, my name is Elizabeth Nugent, and I am pursuing my master's degree in nursing as a psychiatric mental health nurse practitioner. And I chose the problem of depression management as the focus of my evidence-based project proposal. Depression management amongst adults is a serious issue. According to Healthy People 2030, only 64.8% of adults with major depressive episodes received treatment in the last 12 months. Their goal is to raise that percentage to 69.5% by the year 2030, thereby increasing the proportion of adults with major depressive disorders who receive treatment. The intervention that I chose to research for this project was combination treatment of standard care or pharmacotherapy with cognitive behavioral therapy, also referred to as CBT. 3 studies were reviewed, including a systematic review, a randomized controlled trial, and a qualitative study, with all 3 supporting combination treatment of treatment-resistant depression. When compared to standard care or pharmacotherapy alone, combination treatment was found to be more effective at reducing depressive symptoms. The systematic review found that significantly more participants in the combination treatment group had their depressive symptoms reduced, in some studies by greater than or equal to 50% when compared to standard care alone. The randomized controlled trial found that the intervention group receiving combination treatment had greater alleviation of depressive symptoms post-intervention than the control group receiving only standard care, resulting in a mean difference between groups of negative 5.4, a 95% confidence interval of negative 8.1 to negative 2.6, and a p of 0.001. A number of themes emerged from the data gathered in the qualitative study, including medication being perceived as an aid to surviving a crisis, but outside of this, participants felt ambivalent about medication, feeling they were stuck in a drug loop of trial and error, searching for the right medication. Once CBT was undertaken, it was viewed as being guided towards skilled self-management, and most participants felt it helped them to become gradually more autonomous, feel more confident, and cope more effectively with adversities. In this next portion, you'll see the theoretical framework I chose to guide this project, which was Phil Barker's tidal model of mental health recovery. I chose this theory because it focuses on the care continuum and emphasizes that mental health care should revolve around the individual client, continually flexible, taking into account their unique individual life experiences. This theory also emphasizes personal problem solving in the client, as well as assisting them in identifying personal resources to aid in their journey through mental health recovery. Depression is a mental health problem that ebbs and flows similarly, but also uniquely in clients, so it is important to take each client's personal experiences, voice, and sense of self that are ever-changing along the care continuum into account when implementing interventions to assist them in their depression management. As the client takes on new experiences, their experience with depression inevitably evolves and changes with them. So implementing this theory in the PMHNP's practice and search for evidence-based care would certainly support a client-centered practice and improvement of mental health outcomes. Moving on to the implementation of this project, it would take place in the PMHNP's outpatient setting with a target population of adults aged 18 years or older with a diagnosis of depression that has had an inadequate reduction in depressive symptoms after going through at least one antidepressant trial of adequate doses and duration. This is commonly referred to as treatment-resistant depression, also referred to as TRD. So in the outpatient setting, the patient health questionnaire, also known as the PHQ-9, would be administered to both new and established patients already receiving treatment for depression, specifically a monotherapy treatment of pharmacotherapy. These screenings would then be gathered, and those that screened positive for depression would be interviewed for background and history to determine whether they qualify as having TRD. Those with TRD would be educated on the benefits of combination treatment of TRD as well as the risks involved. And then as long as the client would consent to treatment, the combination treatment would begin, and the PMHNP would either provide additional CBT to the client themselves, or another qualified member of the PMHNP's interprofessional team would provide the CBT. The CBT treatment would consist of 16 sessions, 50 minutes long, administered weekly with up to 4 additional sessions if deemed appropriate by the provider administering the CBT. The clients would then be monitored in order to track the effectiveness of the combination treatment by filling out a PHQ-9 monthly for 12 months, with final outcomes being evaluated based off comparison between the last PHQ-9 completed at the end of the 12-month period and the initial PHQ-9. You'll see here under the title Outcome Measures an image of the PHQ-9, which was the screening tool used to measure the outcomes of this project. PHQ-9 is recommended by the Management of Major Depressive Order Working Group and the U.S. Preventive Services Task Force to screen for depression in patients with no diagnosis of major depressive disorder, as it is consistent and reliable in depression predictivity. It is also recommended that the PHQ-9 be used to monitor treatment progress, in addition to assessments of medication and/or psychotherapy adherence. You'll see in the far right corner 2 tables outlining the timeline of this project, which would take place over a span of about 14 months, starting with a month of planning, weekly team meetings, and then identifying and recruiting patients. After this first month, the meetings would go down to being held monthly, and there would be during this same month, there would be one more month of recruitment as data was being collected and assessed. Then you can see in red that the administration of CBT would be taking place over about 4 to 5 months, depending on the client, all while collecting monthly PHQ-9s until the 12th month, when data collection would stop and be compiled to assess final outcomes. So in conclusion, the combination treatment of CBT plus standard care in the treatment of TRD should be considered and implemented in the practice of the PMHNP. The findings that fueled this project advocate for education of clients so that they can be fully informed of their options using their own values and beliefs, plus the evidence-based practice information and education provided by the PMHNP to help inform the care that would serve them best. It also rallies the PMHNP to look beyond the standard of care of mental health clients and educate themselves on what they could be missing in their practice that could be potentially holding back their clients' pursuance of mental wellness. For most individuals, their provider is the gatekeeper to therapy and other various cares, so it's with great responsibility that PMHNP should look over this project and really consider it in their own practice. Thank you for listening to my project proposal.